Hi everybody. Now we're going to move on to Respiratory Disorders Part 2, which we're going to talk about lower. Hopefully you listened to Part 1, which talks about upper respiratory disorders. Just to review the 6 P's of dyspnea, here's a good picture for you. You can pause this if you want to review. So infections to the lower respiratory tract. First, we're going to talk about pneumonia. There are different causes, everywhere from bacteria, viruses, fungal, protozoa, protozoa. Different classifications. If it is community acquired, it's going to happen within 24 hours of admission, hospital after 48 hours. The expected findings. What you're going to see that I've talked a little bit about, especially in the lower respiratory infections, simply because it's going to have more an effect on gas exchange and say O2 levels, is that your older patients are typically going to present with some altered mental status or some confusion with these individuals. Your physical findings, everything from fever to chills, but specifically patients are going to talk about having a shortness of breath or difficulty breathing. Objective data, when you auscultate the bases of the lungs, you're going to hear some crackles and wheezes. Patients may also be coughing, trying to cough up something. Depending on the severity, the cause, whether or not, what type of sputum they might be coughing up, and if fluid is settling into the bases of the lungs, you may see decreased O2 sats. I do, on some of the different disorders, have sound bites, so if you want to take time to listen to what you might hear, this goes over crackles and wheezes, you can certainly do so in the actual PowerPoint. So for diagnosis of pneumonia, when we're looking at different labs, sputum culture and sensitivity, obviously this should be done first before any treatment is provided, so the sample is not tainted. Possible blood cultures. CBC, know your lab values, particularly say white blood cells, because that's going to indicate a possible infection. Chest x-ray may be needed, especially in your older patients, since they're not always going to present the same way that most individuals will with pneumonia. And again, pulse oximetry, obviously, to look at a person's O2 sat. Nursing care, positioning, encourage coughing, deep breathing, know how to teach a patient how to use an incentive spirometer. Nutrition, fluid intake is important. Anytime anybody is sick, body is kind of in a hypermetabolic state, so it actually requires more. And patients who are malnourished obviously have a longer time to heal. Encourage RAS and medication education. So if somebody is starting on an antibiotic, certainly educate them of the importance of finishing that course. Complications, atelectasis, sepsis, ARDS. Again, I've kind of hinted some of the medical management based off of the etiology could be antibiotics. Bronchodilators can be used. Albuterol will provide rapid relief. Atrovent can also decrease pulmonary secretions. Theophylline needs to have close monitoring since there is a narrow therapeutic range and toxicity can occur. Make sure you know the signs and symptoms of toxicity, which are headaches, blurred vision, palpitations, and possibly seizures. Know some of the issues when it comes to medications. For example, antibiotics. Patients are at increased risk for having frequent stools, yeast infections. Need to monitor kidneys in older individuals taking penicillins and cephalosporins. Albuterol can cause tremors and tachycardia, and your impramptropium can cause dry mouth, and you need to monitor them for their heart rate, which is the adjuvant. Here again is more of a pictograph of pneumonia, signs and symptoms. Tuberculosis, TB has a slow onset. Make sure you know some of the signs and symptoms: persistent cough, weight loss, anorexia, hemoptysis, which is frothy, bloody sputum, low-grade fever in the evenings, night chills. Excuse me. Elderly patients will present with altered mental status. Obviously, those at a higher risk are going to be your healthcare workers, those who travel outside the U.S. to areas that have TB endemics, and those who are immunocompromised. So if you look at the different labs that are available, pretty much all of them are going to be able to indicate an active disease or infection, except for the Mantoux test, which is the one that all nursing students have to get. A chest x-ray can see active lesions in the lungs. The acid-fast bacillus smear culture, again, will also show positive for an active infection. Latent infection, remember, a latent infection is basically somebody who has an infection, but they're not contagious, they're non-symptomatic. So, unlike some of our other respiratory disorders that are transmitted by droplets, tuberculosis is transmitted by the airborne route. So as a healthcare professional, you need to be fitted for an N95 HEPA respirator. So this is typically done in most healthcare facilities yearly. If you gain or lose a lot of weight, you should probably refit it for a new mask. If you're going to transport a patient, they need to wear a mask. Take the shortest direct route, but they need to wear a mask. Adequate nutrition is important for these individuals. Medical treatment is going to be anywhere from 6 to 12 months. There's 4 medications. Make sure you review your ATI Chapter 23, page 137, for medication considerations and patient teaching. When you're looking at that information, look at things that are going to stand out, that you would say to yourself, if I was a patient on these meds and somebody didn't tell me, I would totally freak out. For example, rifampin. A patient may have orange secretions, so orange sweat. I would totally want to be told about this. If you also notice too that these 4 medications spell out the word ripe, so hopefully that will help you in terms of memorizing these medications. Patient education, hand hygiene, cough and sneeze hygiene. Sputum samples are taken every 2 to 4 weeks to monitor to make sure that the medication therapy is being effective. And if somebody has active TB, they need to wear a mask in public. Miliary TB can be life-threatening. This is basically when TB actually spreads. It goes into the bloodstream and it affects organs. And it can, obviously, if it goes to organs, it can cause pericarditis. Patients who have TB need to be put in a negative pressure isolation room. Basically, if you look at this picture, air goes in and then it goes out an exhaust system out into the environment. Pleural conditions. Pleurisy is painful, 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 painful. So, if you didn't hear what I just said, it is painful. There are a lot of different causes. A lot of times it's complications of another disorder. But what you see, there is pain that hurts when somebody breathes in deeply, coughs or sneezes. It can be limited to one side or radiate to the shoulder or abdomen. The pain is severe, sharp, and knife-like. So, if a person has a lot of pain, it is difficult for them to breathe. So, in order to help them breathe, we want to treat their pain. So, pain can be treated with NSAIDs, narcotics, and nerve blocks. And obviously, if the pleurisy is a cause of another condition, treat the underlying condition. What you want to watch out for, and part of your management, is to monitor for pleural effusion, which effusion is buildup of fluid. So some of those signs and symptoms are going to be shortness of breath, pain, decreased chest wall excursion, and help that patient assume a position that, guess what, decreases pain. Again, stabbing pain. So if somebody has pleurisy, priority would be treating the pain. And you can push that button in the PowerPoint if you want to hear what pleural friction rub sounds like. So effusion versus empyema. Basically, effusion is fluid, empyema is pus. It can be a complication of a lot of different things. Symptoms kind of depends on the underlying disease. But in the end, what's going to need to be done is have that fluid pulled off. You're going to have decreased breath sounds, decreased fremitus, a dull, flat sound on percussion. If it is severe enough, patients in respiratory distress may have tracheal deviation, have hypoxemia, hypotension, and tachycardia. What needs to be done is a thoracentesis that will actually confirm the presence of fluid outside of a chest x-ray or CT. The fluid needs to be examined to determine possible root cause. And again, it's going to be about treating the underlying cause. Drain the fluid through a thoracentesis. So if a thoracentesis is done, a patient will have chest tubes. So part of your nursing management is monitoring chest tubes, which hopefully you will watch my other video, which is about 10 minutes of the medical management. Make sure you know your different chambers and what it means of what happens in the different chambers. Pain management during pleurodesis. Pleurodesis is basically if there is fluid buildup between those pleural spaces. They actually will put a powder in there that will help readhere the pleural layers to try to help decrease an area for fluid to build up. Teach patients about splinting with coughing, and just monitor the effectiveness of their pain medication, because again, there's going to be a lot of discomfort, and if patients have discomfort and it hurts to breathe, then there's going to be a decrease in ventilation. Trauma related, remember I told you you don't need to know a whole lot about these different topics that I'm going to go into right now, but you at least need to know what they are. Sternal rib fractures, again, higher up the rib fracture, the higher the mortality. A lot of times surgical fixation is rare, and most rib fractures heal in 3 to 6 weeks. Contusion, that's basically an injury with a blunt trauma that results in abnormal accumulation of fluid in the interstitial and intra-alveolar spaces. Cardiac tamponade, we talked about this back in the cardiac unit. This is going to be compression of the heart resulting from fluid or blood within the pericardial sac. And again, what you're going to notice the difference is that putting a patient in a tripod position will help relieve some of that pressure. Pneumothorax and hemothorax. Both of these are going to be diagnosed through a chest x-ray, and treatment is going to be chest tubes. Again, watch the 10-minute video that I have on chest tube management and make sure you understand basically what happens in different chambers in terms of troubleshooting. Know your different masks. Nasal cannula, your venturi mask is going to be a mix of room air and fixed flow of O2, and your non-rebreather is going to be a high flow with 100% O2. Subcutaneous emphysema, this is basically when you have some air that leaks into the tissue planes and it goes for some distance under the skin and kind of causes a snap, crackle, pop sensation when you press upon a patient's skin. You'll see this sometimes in laparoscopic surgeries. That may take a long time, but it will dissipate. So if you ever have patients with this, because it kind of freaks them out a little bit, just let them know that the gases or air will escape. Certain complications, pulmonary embolism. So this is basically a substance. It can be a solid gas or liquid that enters the venous circulation and forms a blockage. DVT is the most common. Basically, you want to help patients try to prevent things, so not smoking, appropriate height and weight, avoid prolonged prolonged periods of sitting, compression stockings. Those are going to be at a higher risk are long-term immobility, pregnancy, long bone fractures, and advanced age. Expected findings: anxiety, a feeling of impending doom, pressure on the chest, pain upon inspiration and chest wall tenderness, dyspnea and air hunger, cough, and hemoptysis. Labs, you're going to see elevation in your D-dimer because it's a response to clot formation and release of fibrin. Degradation product, ABGs, patients will start off in respiratory alkalosis and can progress to metabolic acidosis. In terms of nursing care, I'm going to give a patient O2 to help relieve the hypoxemia and dyspnea. Put that patient in a high Fowler's position. Monitor the respiratory and cardiac status. Emotional support, monitor their level of consciousness and mental status, monitor their PT. If patients successfully are treated for a PE, educate them about Coumadin or warfarin therapy. Also educate them about bleeding risks and how to further prevent future thrombus. So again, typically, first line of medical management is going to be heparin and possibly thrombolytic therapy, which are clot busters. Now remember, anticoagulants are not going to break up a clot, but heparin is going to be used, so PTT monitoring will be important. If a clot is in an area that it can be removed, they'll do an embolectomy. And if a patient is at an increased risk for clots, they may surgically put in a vena cava filter. Complications obviously are going to be decreased cardiac output, hemorrhage, and worse issue with pulmonary embolism is death. And sorry, this picture here, again, if you like pictures, this is another way to learn about a pulmonary embolus. And again, remember, one of the front lines, you're going to be using heparin. Some other things that you want to watch is when you're looking at patients' labs, is watch their platelet count, because sometimes during heparin use it can cause thrombocytopenia. And so again, you want to make sure that you watch your different lab values. Atelectasis is a collapse of the alveoli. You really don't need to know a whole lot about this, but just know what it is, and if there is a collapse, that it can lead to a mismatch of lung ventilation to perfusion, which leads to deoxygenated blood supply to the tissues. And you can go through this here, and this will actually give you some links to some sounds. Ways to prevent it is changing a patient's position frequently, especially from supine to upright, to promote ventilation and prevent secretions from accumulating. Getting up and moving. Learning how to use the incentive spirometry correctly. Chest tumors. Make sure you know how to assess a PAC year history. There's a few examples on the next two slides. And a lot of times folks who do have tumors or cancer, over time what you're going to see is a chronic cough. So make sure that you can do these problems here. If you want to pause it here. Here are your answers. Occupational lung diseases. You don't need to know a whole lot about these, but the big thing you need to know that if you have a patient with any of these is that management is going to be supportive. There's no way to reverse the damage caused by this. And that's it. So if you have any questions for me, again, you know where to find me. Take care.